Hello, everyone, and welcome to Rad Chat. My name's McNamara, and I'm joined by fellow host Julka-Anderson.
Hi, everyone.
So here we are at Uganda Cancer Institute in Uganda, and we're very privileged to have a member of staff with us. Can you introduce yourself, please?
Hello, everyone. Thank you very much, Joe, and that name is McNamara. Well, my name is Karim Mawerere. I'm a radiation therapist here at the Uganda Cancer Institute. Well, I've been here since 2014, having joined as a diagnostic radiographer and later converted into radiation therapist. Yeah, briefly, that's about my introduction.
Why did you decide to go into radiation oncology rather than diagnostics?
Honestly, it was not my choice to become a radiation therapist. I worked as a diagnostic radiographer for some time in private institutions, and when I wanted to join public service, I was told the only vacancy exists in radiation therapy. By then, I didn't have much knowledge, information about radiotherapy, but I took up the offer. When I joined, I realized things were quite different from diagnostic. In diagnostic, we see patients who are generally not sick patients who have just come to find out whether, to do medical checkups, who have pain but not as much as compared to patients you find in the radiation oncology department. So on first arrival in the department, it was a shock. People who are terribly in pain, they need assistance. And it's like the people who are available to offer the assistance don't match the numbers. The ratio is too high compared to the service providers. So that alone made me think twice. Should I stay in my comfort zone of seeing patients who are relatively not so sick, or I join the profession where you find people who are who are in too much need, but again, there are no people ideal to offer the services they need. However, mentally, you're somehow broken. It's like from point A, you come to point Z. It took some time to decide whether to stay or to go back. However, from consultation amongst the people who I usually consult, I went to uh, the, the person who gave me much courage to stay was my imam, my religious leader at the mosque. I told him the story. Like, I don't think I can manage those conditions. You see, when you move through the radiation oncology department, you see pain. You see pain before you see the people. Pain comes to you before. So you put yourself in those shoes. I'm like, I think I will not manage. I'm not mentally prepared to go into this. And we talked over it for some minutes, but what made me completely change my mind and decide, he read for me a verse from the Quran which says that whoever saves a life, it's like you have saved the entire world. So I'm like, okay, now let me go and save a few lives there. And it's like, to appear as if I've saved the entire world. So mentally, I started preparing myself to handle these extreme cases of pain, tumors of every, anything you can think about tumors. We have a variety here at the Uganda Cancer Institute. So we moved on, and we got so much attached to our patients until the thought of reverting back to diagnostic completely disappeared. And things became so much, I became so much attached when my own mother became my own patient at a certain time in 2000, actually. She was diagnosed with breast cancer, a condition I came to realize that she had it for more than 4 years. Now breast cancer presents a lump, and she didn't care and could not talk about these issues because she was like, I'm getting some medication elsewhere, until we convinced her to come, and it was confirmed that it was breast cancer. So we treated her. By then she was 65 years, now she's 70, and she's happy living. So that made me again become more attached, because what I went through, whenever I'm handling a patient, I know the relatives are going through the same thing, and to give you a lot of attachment to your patients and so on. So briefly, that's how I came into radiotherapy. It was not something I knew of at first, because information about radiotherapy and radiation oncology is limited out there. You only come to know it when you get it.
Do you find that the culture in Uganda, lots of people avoid getting checked by the doctor?
Yes, there is phobia. When people hear about the word cancer, what comes to their mind is death. That's generally what is in the population. However, of recent, there is a lot of awareness by the Uganda Cancer Institute and the government as well. And people are coming to realize that when you're diagnosed with cancer, that doesn't mean the end of you.
Yeah.
There is a solution, and there are several solutions. So this has somehow tried to change the perception. But as I've told you, through conversation with my own mom, who had people around her were discouraging her to come for treatment.
Yeah.
They have it in their mind that when you go for surgery, you're going to increase the rate at which the disease spreads.
Right. Okay.
When you go for radiation therapy, here we call it, if you are to translate it, it means the word we use in our local language translates into electricity. So it's like you're going to be shocked.
Oh,
And
right.
you will not
Okay.
come, and you will not come back to life. And the thing is that most of our patients report late with
Yeah.
advanced diseases. So when they report with advanced diseases, and when they are sent or referred to radiotherapy for palliative radiation,
Yeah.
usually their chances of survival are not so high. So many end up dying. So the people take it that my patient was at home
Yeah.
and he was still alive. But when he went to radiotherapy, when you go to radiotherapy, he
Yeah.
passed on. So this radiotherapy must be a wrong thing. So
Yeah.
that perception is there. But as I said, with awareness and public awareness, there's a lot of public awareness these days. People are coming to realize that no, it's not the cancer treatment that causes the death,
Yeah.
but because we report late. So there's a lot of screening nowadays going on in the different regions.
Yeah.
If you went through the compound, would see buses, those yellow buses. Those are screening vans. So
Yeah.
they go to the community, give education to people, they screen, and where there's suspicion, they send them here for confirmation.
Yeah. So better education for
It's education,
patients
yeah.
will hopefully help.
Though it is still limited, but it is doing.
Yeah.
That's why you find great numbers. Numbers are increasing every year.
Yeah,
It's
because
not
there's
that
better
it's
screening, better
yeah.
awareness.
And then what is it is sending the population? Some people have a feeling that the rates of cancer have increased when they come here and they see the numbers, but
Yeah.
it's not. It could be contrary to that. It's because of the screening awareness that is bringing a lot of people to the Cancer Institute.
Yeah.
Contrary to what used to happen, people used to die in their homes without knowing
Yeah.
the causes of their deaths.
So obviously, part of the mentorship program that Dr. Katie Wakeham and Dr. Solomon and Dr. Israel kind of have introduced, and obviously having Numan and I here, and also Claire and Jack and Tony, what's the impact of our kind of visit? Why do you think these kind of mentorship and support programs are important?
First of all, I would begin by thanking Dr. Katie for loving us so much. She has always been here. She has always supported us. And I think she has passion for patients in Uganda.
She definitely does.
Yeah. Well, it's a bright idea and we buy into it. We just need more support in terms of education materials and any other form of literature that will help us to get enough information and knowledge, and we shall be able to pass it to others. I don't know the scope of your mentorship programs, but we also have a feeling that if we are hoped to improve or to advance. Because as we talk right now, I think we have one radiation therapist who has a master's and it's not in radiotherapy. So we need also to advance in the field of radiation therapy so that we can be able to pass on or to teach in our own university. We have a university which has a program in radiation therapy, but we don't have the lecturers. And the main reason is because we don't have people who are qualified to lecture. So if we can be helped somehow to advance in our professions and be able to be enrolled in the university and recruit more students into the program, it will be very helpful. As I mentioned earlier on, most of us came in as diagnostics. Got training on job. Later, the IEA came in and helped us train and so on. But it's not enough. We need more. The numbers on the number of radiation therapists vis-a-vis the patients, the ratio is too. We can say it's negligible. We have the equipment, though not. We have a number of equipments, but people to operate the equipments. So we need to have a program here, but it involves higher education. Otherwise, as for this program of extended roles care, that looks at caring the patient, something I would call something like holistically patient. You have a conversation with the patient, they tell you what they are going through, you give advice, the non-pharmaceutical, management. We are willing to take up the responsibility, though the numbers are also still so small. Well, as we said, we want to be guided on how to develop and implement the protocols in our setting. We may be having protocols, but they don't so much fit in our settings. Now that you have seen the picture, exactly what is on ground, so we can help to reconcile the two, the normal, the required, and what can be implemented on ground. That's one aspect. Then the other aspect is also when you go around, you can see there are some few things, especially that can be used in the immobilization and reproduction of setups and etc., which we may not be having. If you can, you avail them. If you, in any way, if you can have a few areas where you can get a few that we lack. Some are so simple, but because of certain reasons we don't have them. We would also be appreciative if we had some of those things availed us as we come. And also, I don't know whether you looked at our curriculum. If you see any gaps here and there, maybe when you go back, you can have a few inputs here and there, then you share. But before you come back, we would also would love to keep in touch. Some of same is and anything that can be helpful to.
You won't get rid of us now. Now we're linked in. There's no getting rid of us.
We have no problem with that. Anytime there is an opportunity, we are willing to take it up.
Yeah, absolutely. Well, thank you for joining us on Rad Chat. It's been great to kind of have your conversation. Are there any top tips for anyone listening out there that you would love them to take on board?
Well, as I mentioned earlier, our patients report late, and we would encourage patients to go for screening services. Anybody who has been suspected of anything, please report to the institute, report the department. We are willing to handle you and to go through the cancer management journey with you. Secondly, anybody who has any ill feelings, misinformation about radiotherapy, you are free to come in anytime you want, visit the department, talk to any health worker. We shall tell you whether the benefits of radiation therapy. There are risks involved, but minor. We can talk about that when it comes to that particular time. Anything you want from radiotherapy, we are willing to offer the information. And we are thinking of in future to have either it can be a podcast or some radio or TV shows specifically talking about radiotherapy services, what they are, what you benefit from them, where, how to access them, and any other thing in that line.
Brilliant. Thank you very much for joining us here on Rad Chat.